Good afternoon. I'm Bob Wachter, Chair of the Department of Medicine at UCSF. We have a special Grand Rounds today on gun violence and the epidemic of gun violence, and focusing on what we know about the science, which is incredibly important as we also work through some of the incredibly complex political and cultural issues that are part of this particular issue. Just a couple of notes before we get started. CME is available. If you're interested, stay on at the end and instructions will be available to you. Closed captioning is available. If you have questions, please type them into the Q&A box and we will get to as many as we can. And just an announcement that this is our last Grand Rounds for the season. As always, we go on break over the summer months and come back after Labor Day. There is a special conference on the 14th, my stewardship review after 5 years, being presented by Dean Talmadge King, and we're sending out an announcement about that. And we'll always reserve the right to have a special Grand Rounds if there's some emerging issue that we think merits coverage during our hiatus. But otherwise, you can plan to have your Thursdays at noon back to you and have a great summer. I won't spend any time on the context here. Everybody has heard about not only the large-scale mass deaths and shootings over the last couple of months, but the steady drumbeat of firearm violence that continues through our country, which is tragic and shameful. And we are lucky to have three speakers to address different aspects of it. The plan will be 2 talks, and then we will open it up to a panel discussion. The 3 speakers are Dr. Jahan Fahimi, who's an emergency medicine physician, serves as the medical director of our emergency department here, and the UCSF Health Medical Director for Value Improvement, in which he focuses on how to maximize quality and safety and equity, and also lower the cost and eliminate waste. His research interest is on firearm violence in the United States, and he takes a scientific and advocacy approach to that, trying to understand how to address the health system and physicians and other health providers in moving the ball forward. John earned his MPH at the Harvard Chan School of Public Health, his MD at NYU. He did his residency in emergency medicine and a research fellowship at Highland before joining our faculty. So John, welcome. Second speaker will be Rebecca Plevin, who's assistant professor of surgery in our Division of General Surgery, Trauma and Surgical Critical Care. Her focus is on injury prevention with a particular focus on underserved and vulnerable populations. She also directs the San Francisco Wraparound Project, a hospital-based violence intervention program based at Zuckerberg San Francisco General Hospital. She received her undergraduate degree from Berkeley, her MD from USC, her residency in general surgery at UW in Seattle, and then did her trauma and surgical critical care fellowship at UCSF, and she practices quite broadly in general surgery as well as trauma surgery, surgical critical care. And then finally, last but not least, and he, I believe, is busy clinically now, so will join us toward the end, is Andre Campbell. Andre is professor of surgery in the Division of General Surgery, also vice chair of diversity, equity, and inclusion at the Department of Surgery. Andre is a renowned clinician educator at UCSF. He's received numerous awards from the medical students for that work. He's a member of the DeVos Academy of Medical Educators, has served as the clerkship director for our third-year students in surgery, and has also been director of the UCSF Surgical Critical Care Fellowship for a long time. He's got leadership roles in the American College of Surgeons, where he is a master surgical educator. Andre attended Harvard Med School at UCSF and did his surgical and surgical critical care training at Columbia, and joined us now 2 decades ago, where he's made a tremendous difference in our care of patients as well as medical education in surgery and surgical critical care. So thrilled to have our 3 speakers from all from outside the Department of Medicine. One of the things we like to try to do is bring in outside voices. And so with that, let me hand the podium over to Jahan for the first talk.
Excellent. Thanks so much, Dr. Wachter, and thank you for having us here to have this conversation. I'm going to go ahead and share my screen here. So with that introduction, I'll just dive right in so we can save some time. For those of you who've ever heard me kind of talk about the issue of firearm injury and firearm violence in America, I always kind of frame this as a problem where to understand the problem, we need to think about numerators and denominators. I think if we start there, it allows us to have kind of an even playing field so that we understand the scope of the problem and can have a more nuanced conversation. So what I mean by that is if the denominator is all firearm casualties, including fatal and non-fatal injuries, what we can kind of take a look at in this graph is to see that, what are the most common mechanisms or intents of injury? And within each, what's the ratio of fatal to non-fatal injury? And really, this emerges as a story of community violence in America, where we see the amount of homicides and assaults with firearms really being the primary driver of firearm casualties in America. Now, one caveat is that this data is from 2014. The CDC Whiskers database has stopped updating casualty information due to some statistical issues. But this is kind of the latest that we know, and we think that these trends have largely held true. You can see that there's a significant number of accidental injuries each year, and there is a separate category specifically for legal intervention or police shootings, which you can see is not insignificant, but is much smaller as compared to some of these other mechanisms of injury. So that puts us, a big picture. What do the casualties look like? But if we wanted to look at deaths specifically, and we looked at homicides and suicides in America, and then looked to see what's the proportion of those deaths that involve a firearm, you can see that suicide kills more Americans than homicide does, right? So if we're talking about deaths, suicide is a much bigger problem. And even though I say only, but only half of suicides involve a firearm as compared to 80% of homicides, the denominator of suicides is so much higher that the absolute number of firearm suicides still outstrips the number of firearm homicides. The couple points to make about this. One is that this is a bit of a moving target, right? If we go back a few years, that proportion of firearm homicides is actually much smaller. And so the overall homicides in America are increasing, and the proportion that involve a firearm are also increasing, such that, I would guess in a couple of years, we would look at this graph and we might see deaths from homicides involving a firearm outstripping deaths from suicide that involve a firearm. If we collapse that whole graph and we look at it this way, you can kind of see about 54% of firearm deaths overall are suicides, 42% are homicides, and together that's 96% of all firearm deaths fall into one of those two categories, leaving about 4% of other mechanisms. So we can see, a little over 45,000 deaths per year attributed to firearms. And so what's causing this, as I mentioned, this increase, right? So the CDC will point you to the fact that there's this long-standing systemic inequities and structural racism that limit economic and educational opportunities. They contribute to unfair and avoidable health disparities among some racial and ethnic groups. And against the backdrop of the COVID-19 pandemic, the substantial increase in firearm homicide rate, along with notable increases in firearm suicide rates for some groups, has widened racial, ethnic, and other disparities. And what they're really specifically reacting to here is the fact that that rise in homicides, and particularly firearm homicides, is disproportionately in Black populations. There has also been a small but not insignificant rise in suicides, and that has been largely in the Asian and Pacific Islander populations in America. And so these are, it's a lot of moving parts, but what we're seeing is this kind of health equity and inequity picture really emerging. So every time I do this talk, I try and put firearm deaths in America in the context of other medical conditions, because I think that it's really important. I mean, we're here at Medicine Grand Rounds. This is a health and public health issue. And so we should really be thinking about this in the context of other diseases as well, right? So this wouldn't be Medicine Grand Rounds if we didn't talk about COVID. But so in 2020, 350,000 deaths due to COVID. Now, if we go way down the list and we look at other disease entities that we all think about frequently and that kill about as many Americans as firearms, we see, ranges from prostate cancer to kidney disease. And what's striking about this is two things I'll point out. One is there are more firearm deaths than there are motor vehicle accident deaths. And, against the backdrop of falling motor vehicle accident deaths over the last few decades, as cars and roads have become safer, firearm deaths have slowly risen, such that, a few years ago, there were more motor vehicle deaths than there were firearm deaths. And now those numbers have crossed for the last few years. The second thing I'll point out is, let's take alcohol and alcoholic liver disease, right? There's an entire NIH institute dedicated to studying alcohol use and alcoholism, right? Or if we look at sepsis, every time my patient has a lactate of 2.1, the EHR is screaming at me to do something to save them from sepsis. And it just goes to show you that how much, research and effort and funding we have put towards all these disease entities. But as clinicians in medicine, nursing, and all the other health professions, I don't think we have the same understanding or resources within the health system to address firearms. So how do we begin to fold this into sort of a medical or health professions context, right? So I like to take firearm injury and violence, which is this very heterogeneous topic, and organize it into these sort of contexts, right? So community violence, intimate partner violence, self-harm, mass violence, which we hear a lot about, even though it's relatively rare, accidental injuries, and then, as I mentioned, legal intervention or when law enforcement is involved in a shooting and death. And so within these contexts, we can think about sort of different domains, clinical domains or domains of expertise that healthcare professionals, need to have in order to be able to address this as a health condition, right? So there's primary medical management, which I would argue we're quite good at. There's the mental health and psychological care of patients that are either at risk or have been injured. There's risk assessment and screening, which looks very different when you're thinking about, say, intimate partner violence, for which we have some data, as compared to mass violence, which is incredibly hard to screen for. There's primary and secondary prevention. And then, of course, we always want to be thinking about, as clinicians, physicians, nurses, other health professionals, how do we advocate for our patients' health? And then what are some of the legal requirements, right? We're mandated reporters in many instances, and we need to be thinking about what the legal implications of caring for these patients might be. So, in an ideal world, you have these kind of different domains, right? We have health policy focus on tackling this issue. We do research on the issue. There's an advocacy piece, and then there's the patient care. We think about this approach for so many different disease entities. And a few years ago, I would have put the research bubble further away. It wasn't really in the mix here, but the truth is we're starting to get more federal funding. So it's now kind of in this. But I want to focus on the patient care side of things, because I think, as I've said, as clinicians, many are ill prepared and supported to do the patient care of patients who are injured or at risk. And so the question, we may ask is, what do clinicians need to know at the bedside to improve care for at-risk and injured patients and prevent future firearm injury and violence? And so there's this sort of new emerging bubble, right? So health professions education, how do we bring that into this so that there's an education bubble in the mix? So this is a publication that I worked on that was published earlier this year in academic medicine. And what we did, this was a colleague of mine from Johns Hopkins, and I convened a nationally representative group of experts to derive learning objectives that can inform clinical design, curriculum design, to address firearm injury education in America. And so, had representatives from all sorts of disciplines within medicine, from public health, from nursing, injury prevention experts, and medical education experts, including Dean Davis from here at UCSF and two of our fantastic medical students. And what we did is we sort of organized the different contexts of injury and then thought, what are some educational domains, particularly epidemiology, patient-centered care, and then the ethics, law, and policy considerations, and tried to come together with, priorities that, different schools of health professions could begin to, literally pluck from this list and learn, figure out how to incorporate into their curriculum. And this is the process we took, right? We took 30 some odd experts from across the country who generated about 600 ideas about what should be taught in health profession education around firearm injury prevention. Those were sort of coalesced into 111 different themes. And then we did a round robin process and came up with 141 priorities. We then kind of ranked all of these, culled it down to 89 priorities and voted on those, when ultimately came up with 58 distinct priorities that we thought were important. We then engaged some external stakeholders and key sort of experts, and ultimately ended up with 51 final priorities, which I'll kind of show you in a second. If you look at the breakdown, this matrix kind of shows you where these 51 priorities kind of fall, right? So in the sort of general category of firearm injury, there's 3 that have to do with epidemiology and social context. There's 6 patient-centered care priorities. There are 3 ethical, legal, and policy implications. There's 1 that has to do with, just understanding firearm anatomy and physiology. And you can kind of see kind of the distribution here. We tried to cover as many domains as possible and make sure that we're exhaustive in all of these contexts of injury. We also had 4 priorities that really had to do with organizations and health systems and how they can, contribute to the mitigation of injury and death. So in order to kind of transition over to what Dr. Plevin's going to talk about, I thought I would maybe kind of focus in on the epidemiology and social context of peer violence or community violence as an example of what some of these priorities look like, right? So I'll just go through this. The first priority was, to understand the impact of the social determinants of health on firearm injury and death. And we considered this, generally speaking, a basic concept. But each one of them had sort of branch points, right? So explain the risk of firearm injury and violence as affected by many social determinants of health, including but not limited to social support, social networks, racism, concentrated poverty, access to educational and economic opportunities, and adverse childhood experiences. And you can kind of see this is starting to mirror a little bit about what the CDC was talking about earlier this year. And we think, again, this is a basic concept. This should be embedded in undergraduate and graduate health professions, as well as, we need to begin to think about how we retrain the practicing cohort of physicians that are out there now to understand some of these things. And as you can see, we can go through, there's, describing the epidemiology of intentional, non-fatal firearm injuries and firearm homicides. And then as a branch point of that, the types of firearms that are used, specifically that handguns are oftentimes used in many of these injuries. And then we can go to a more complex concept from there, right? Describe how crime guns may be obtained, right? Legal purchase, straw purchase, theft, loans, and how they are often stored or carried. We think it's a much more complex issue, but we think that for certain physicians, that becomes very, very critical depending on your specialty and your practice environment. And so I won't go through all of this, but this just gives you a flavor of what the priorities look like. And, as I mentioned, there's 51 of these that can be used to kind of hopefully be fairly exhaustive in beginning to kind of retrain and rethink about how we teach this. So where do we go from here? I think we need to bring education into the fold of some of these other domains that we think about when we're talking about firearm injury reduction. We need to educate the next generation of clinicians and retrain this generation across all health professions to consider firearm injury as a medical condition. We need to reframe firearm injury from a social phenomenon into a health disparities context. And then I think we need to develop tools and resources within health systems and communities, which I know that Dr. Plevin will talk about, to support and empower clinicians to improve outcomes for patients that are at risk or injured by firearms. And so with that, I will turn it over.
Thank you, John. That's very helpful. That's a way of framing it and thinking about it in a more scientific and educational context. That's great. Let's turn it over to Rebecca. And as I said, I see Andre's joined us. We have a second talk, and then we will open it up, give Andre a chance to make some comments, and then the four of us will chat. So Rebecca, you are on.
All right, give me 1 second to get my screen shared. Okay. All right, well, thank you, Dr. Wachter, for the opportunity to talk about what, in my mind, is one of the most pressing issues today, which is gun violence in our community. As was already mentioned, I'm a trauma surgeon over at San Francisco General, and I'm also the co-director of the Wraparound Project, which is the Hospital-Based Violence Intervention Program, or HVIP, at San Francisco General. So my goals today are to give a brief overview of the theory behind HVIPs, to describe how Wraparound works for those who aren't familiar with the program, and then to briefly present a couple studies looking at the impact of HVIPs. It's a lot to cover in a short period of time, so I'll share my email at the end, and please feel free to reach out with any questions. Dr. Fahimi gave a really great overview of the scope of firearm injury and deaths in the United States. As we focus in on community violence in particular, I'd like to again underscore the fact that injuries and death from community violence, and particularly from firearms, do not impact all communities equally. Young African-American and Latino boys are much more likely to encounter violence in their daily lives and to die as a result. And homicide is the #1 cause of death in African-Americans and the #2 cause of death in Latinx people between the ages of 15 to 34. So it's important to think about community violence as a public health issue. And by that, what I mean is it's a health problem that can and should be addressed through this public health framework of defining the scope of the issue through data and research, identifying risk and protective factors for community violence, developing and testing interventions to mitigate risk factors and enhance protective factors, and then evaluating the effectiveness of interventions in order to scale those that have the greatest positive impact. The goal of a public health approach to violence is to mitigate those modifiable risk factors and to enhance the protective factors. And of course, as we all know, violence doesn't just impact individuals. It impacts families and communities and society as a whole. So modifiable risk factors for community violence exist on a number of different levels, from the individual and the interpersonal levels, all the way up to policy level factors like the way that crimes are prosecuted in our cities. And baked into these risk factors, and particularly ones like differential economic opportunities or the absence of protective institutions, are the impacts of structural racism, which cements systemic inequities among specific racial and ethnic groups. And these modifiable risk factors for violence are components, as we know, of the social determinants of health. And poor social determinants of health, such as unstable housing, low income, unsafe neighborhoods, and substandard education, contribute to disparities in health outcomes, including mortality, shorter life expectancy, and long-term functional limitations. Conversely, protective factors for violence like mentorship structures, access to financial and education resources, and access to mental health care have positive outcomes or have positive impacts on health outcomes. So the goal of an HVIP is to address modifiable risk factors for violence and enhance the protective factors within the social determinants of health in order to improve health outcomes. So now let's talk a little bit more about violent injuries. HVIPs capitalize on the fact that violent injury is unfortunately a recurrent disease. Recidivism for firearm violence is as high as 26% in some studies, meaning that 1 in 4 people who are shot will be violently injured again in the future. In another study, 1 in 5 homicide victims was found to have been treated for a violent injury within the 5 years prior to their death. In addition, that second injury tends to be more severe with both higher mortality and survivors who have a worse prognosis after their second injury. The second injury is also more expensive, both with respect to the cost of the hospitalization itself, but also the societal costs from lost productivity in patients who die as a result of their second injury. And because patients who are victims of community violence once are more likely to be injured again, HVIPs use that first injury as an opportunity for violence intervention before the second injury occurs. There are a couple cornerstones to the HVIP model. The first being that they're grounded in the public health approach, like I described. The second is the concept of the teachable moment. And you may be familiar with the teachable moment as a health event that catalyzes patients to be receptive to exploring major behavioral and life changes in order to improve their health. For example, quitting tobacco use after sustaining an MI. In the context of violence prevention, the time period immediately after injury is that teachable moment. It's an opportunity for a wraparound violence prevention professional, or VPP as we call them, to develop a relationship with the patient, explore their needs with respect to underlying risk factors that may have contributed to their injury, and offer wraparound services. The third cornerstone of the HVIP model is the use of long-term culturally competent case management. Our VPPs have deep ties to and experience working in neighborhoods and communities in San Francisco that are deeply impacted by community violence. And this cultural competence is absolutely critical to wraparound success because it enables our VPPs to quickly develop deep relationships with clients and their families during that window of the teachable moment, and to help them navigate through the communities in which they live after they are released from the hospital in a way that a case manager without cultural competence would not be able to do. This cultural competence is also really important in developing and maintaining relationships with community partners who are instrumental in providing services to our clients. And then lastly, our VPPs serve as a gateway to a number of risk reduction resources, which I'll describe in more detail in a minute. So every program functions a little bit differently, but this is the general wraparound workflow. When a patient injured by community violence arrives at the hospital, of course, the first priority is for them to receive their initial trauma care. Once they're medically stable, a wraparound VPP meets the patient at the bedside, taking advantage of that teachable moment. The VPP then performs a risk assessment and offers the highest risk individuals enrollment into the wraparound program. Enrolled clients typically spend 6 months to a year in the program, although there are some who remain with wraparound for longer, depending on their specific needs. So what does wraparound provide for our clients? In addition to 6 to 12 months of case management, VPPs provide brief crisis intervention for clients and their families. They assist with victim of crime applications. They provide community support, and they provide linkages to a wide variety of services, including vocational training, mental health support, help obtaining education or employment, housing assistance, and enrollment in youth programs. We do have some programs that we run in-house, but wraparound relies really heavily on relationships that our VPPs have built with community-based organizations who are doing work in these areas. These organizations are another key piece to our puzzle because they allow us to provide a much more comprehensive set of services than we could provide on our own. And our goal is really not to reinvent the wheel when there are so many really good community organizations doing work in all of these spheres. So now I'm going to briefly review a couple studies looking at the impact of HVIPs. This study was a 10-year evaluation of wraparound outcomes. It included 466 of our clients, and the study found that the violent injury recidivism rate decreased or was 4.9% for wraparound clients, and that was down from a historical control rate of 8.4%. The most common needs identified among our clients were mental health, victim of crime services, employment, and housing. And overall, wraparound was really effective at addressing these needs, although employment was one of the more challenging. In addition, the study found that meeting educational needs was protective against future re-injury. The wraparound team also performed a cost analysis in 2015, which found that the program was both cost effective and led to gains in quality adjusted life years. This finding has been echoed in a similar study of the HVIP over in Oakland at Highland Hospital, where the investigators conducted a similar cost utility analysis comparing participation in the HVIP with standard risk reduction practices. They found a decrease in injury recidivism from 4 to 2.5% and found that their program was also cost effective. And because both of these studies approached cost from a healthcare perspective, the models didn't even take into account the savings, the dollar savings that HVIPs create from a societal perspective by preventing re-injuries, preventing deaths in their patients. So there are a number of similar small studies looking at HVIP efficacy, but larger evaluation has been challenging because of variation in program structure and data collection, and really the need for more robust national data. To address this, there is currently a national HVIP database that is accruing data on outcomes in programs throughout the country with a goal of providing a more comprehensive evaluation of HVIPs nationally once we've accrued enough data. And while re-injury rates are one important measure of how well HVIPs work, there are also other more nuanced research questions that we should be asking about these programs and their impact. And to that end, one of our surgery residents, Dr. Hannah Decker, published a study investigating the attributes and behaviors of our VPPs that made them successful in providing case management services. This was one of the first studies looking at HVIP research from the client's perspective and in their own words. Dr. Decker performed 24 semi-structured interviews with previous wraparound clients. And from those interviews, she identified 6 key themes that were important in the successful development of a therapeutic client VPP relationship. So these included the ability of the VPP to relate to the client's socioeconomic context, to navigate the in-hospital teachable moment and exhibit compassion for their clients. Their ability to act as role models and engender respect and pride in the clients, and their ability to serve as portals of opportunity. I wanted to highlight a few quotes that Dr. Decker pulled out from her interviews to close this talk as examples of these key themes. It's incredibly important that in addition to looking at re-injury rates and cost analyses when we talk about HVIPs, we also highlight the lived experiences of our clients and use them as equally important measures of the success or failure of these programs. I think that these quotes really poignantly describe how impactful our VPPs are on our clients and on our clients' lives after they participate in the wraparound program. And to close, I, of course, want to introduce you to the heart of Wraparound, who are the three people at the top of the slide. Many of you may know Mike Texada, who's our supervising VPP, and he's been with the program nearly since its beginning in 2005. He is a remarkable person who's contributed enormously to San Francisco General Hospital, to our patients, and to the city of San Francisco. And Terrell Henderson and Vanessa Jackson are our other two frontline VPPs. They are the ones doing the boots on the ground, real work of Wraparound. And these three are the reason that our program is successful. And then lastly, I'd like to thank my co-directors, Dr. Lauren Chalwell and Nancy Anaya, both of whom are faculty within the Department of Emergency Medicine, and who I'm really grateful to have as partners in this work. Thank you.
I appreciate it. Let me turn it over to Andre. I think you've gotten a chance to listen to some of the presentations. Give you a chance to, I don't know if you have any slides or just a chance to riff on kind of your thinking about this topic for a few minutes, and then we'll bring on everybody and we'll chat. You're on mute.
Yeah, of course I'm on mute. I can't figure out how to use Zoom after all these
You'll
years.
get it. You'll get it.
It's great to see you, Bob. I've seen you a lot over the last couple of years and all the wonderful things you've done. And it's great to be here speaking with all the members of the Department of Medicine. Just a couple of thoughts I have, and then we'll answer some questions. We could just chat about things. You've heard a lot of great discussion from both Dr. Fahimi and Dr. Plevin about issues related to gun violence. And I just wanted to give a little bit of background from the advocacy point of view, and then open up for questions. So this has been obviously a thorny issue for many years. I mean, in California, we've actually been ahead of the curve in many ways. And so we had an assault weapon ban here because of a school shooting in the late 80s in Stockton that killed 6 children. Then there came the assault weapon ban nationally. Then there's been a lot of studies looking at the impact of banning these weapons on gun violence, and things have really been stuck a lot over probably the last 15 years since the expiration of the ban, and that's because nationally there's been a lot of stagnation. But what's interesting during that time, there's probably been about somewhere between 15 and 20 states that actually have moved ahead to do things, and that has really kind of changed things. Now, more recently, we've had this movement, which I think is interesting because some people think it didn't go far enough when the president just signed the law that was brokered in the Senate. Some folks said it didn't go far enough and it didn't touch the issues of more in-depth background checks and all the things we agree on, and banning assault weapons. It's clear that scientifically that banning assault weapons reduce the amount of violence. But you would think that after Sandy Hook 10 years ago, now recently Uvalde and Las Vegas and so forth, that people would have really sort of come around to really see the importance of really having gun safety, because used gun control kind of alienates folks. But gun safety, I think, is a better way to think about it. So advocacy happens locally. We have been fortunate because we have mayors who have been forward thinking. Now we have Mayor, London Breed, who's been fantastic, Supervisor Stephanie. They've authored legislation locally to make changes. We have done things, we meaning the American College of Surgeons and others, and emergency physicians and other types of physicians who've advocated this at the state level, but pushing for different laws that we can. More recently, we're actually close now to getting the Stop the Bleed legislation passed after multiple testimonies there, and then the national thing stuck, and all of a sudden after 30 years we have made some changes. But I'll just sort of say a couple things, reflections on my thoughts about this. Advocacy comes in different ways. And I think you have to kind of seize the moment when you have it. A number of years ago, we had a mass shooting here, the YouTube shooting, and I was asked to speak in front of the media to talk about that. And actually, when I was walking out there, they said, you can't say this, you can't say that, you can't give details. So I ended up kind of lecturing to them about what we do on trauma patients. But when they started asking me questions, I basically told them that when the poor people get shot, you don't come here. But when the rich people who are shot at YouTube, you see it. Because every night, Becca and I and the rest of the emergency physicians here and the trauma surgeons, we deal with this regularly. I've been here long enough where I've operated on fathers, mothers, sisters, brothers. When they walk in the room, then I know them because I've saved their whole family's life over the years that I've been here. And then what happens, I went out there and I said that, and I caused reverberations. I I went viral. There's hundreds of thousands, millions of views of what I said. And actually, as a result of that, I had a number of really threatening letters and phone calls because of that. Because when you stick your neck out, you do have it. But I think it's important that as physicians that we stand up for things. More recently, the university has done a great job related to the issue of Roe versus Wade versus gun violence. But I think I want to close by saying that we have to use our voice as physicians, as people who are respected in the community, and that sometimes you got to be called on, whether it's a governor asking you or the Speaker of the House, which I just recently done, or Congressman Thompson has been pro gun reform, even though he's a gun owner for many years, that we have to be willing to stand up, say what we have to say, and really try to make a difference, because our voice is important. And I just kind of urge you, don't get discouraged. We have to always think positive that we can make a difference and move the needle, because the needle has moved just recently, and we need to push more for it. But I think that we're beginning to make progress in this area. But I just wanted to thank you for inviting me. Sorry I'm late. I'm operating today. I just ran out of the operating room to come over here to add to this. But I'm happy to answer any questions about any of these topics. And I just want to thank the other panelists, because they've done a really outstanding job laying out the problems. And the wraparound program has really revolutionized the way that patients are cared for in San Francisco, and it's led the way. It's one of the first programs in the whole country for hospital-based violence intervention program, and the success they had is really pretty legendary. So with that, I'll wrap it up after singing the praises of San Francisco General, and I'll give it back to you, Bob, and happy to answer any questions that you may have, for me. And I'm sure Becca could come on and answer things.
Great. We'll have Rebecca and Jahan all come on. So thank you, Andre. I hope you finished up the surgery before you left.
Yeah, the surgery's going fine.
I'm glad. Let me start with you. As you kind of decided, I don't know whether you made an intentional decision or it was sort of in the moment of that shooting to sort of be unplugged. How did you feel like you were putting your career at some sort of risk? What kind of support do you feel like you got from the university or not? Because I think that's an issue that comes up as we talk about gun violence or abortion or a whole bunch of issues among faculty and trainees. It's do I need to stay in my lane? Do I need to be careful here? So how has this been for you? And did you kind of make an intentional decision to be this way, or did you sort of start being this way and see what happened?
Well, I'll tell you, Bob, I've known you for a long time, and what I said is something that I say every day, and I wasn't really anything that was unusual. And Becca's smiling because I was just being me. Right? I just got it fun. I just said what I thought. People who saw me across the world, they said, "Oh, that's just you being you." And the thing that's interesting, you talk about staying in your lane. What had happened is the NRA had said some things related to the ACP statement, American College of Physicians statement about it, and actually started this national and international movement about staying in the lane. And this is really our lane. We take care of these folks. They basically come in, and we feel very close to these patients. And I actually have to say that both locally here at San Francisco General, in terms of leadership, and at the university, everybody's been incredibly supportive. Our chair and any of the folks I ran into. So I think this is clearly our lane. We have to stand up and say what we have to say when it's time. And I have no compunction doing that. Now I have to say that it's sometimes you'll get blowback, and that's just par for the course. But we got to stand up for what's right. And it's clearly, I didn't say anything. If you look at what I said, it's not controversial. But then, of course, people thought it was controversial. I just kind of said that what we say every day when we go down there and have to pronounce a young African American kid who's 16 years old who's dead. I mean, that's just, this is what we see all the time, and I've seen it for many, many years. And these kids, they look like me. They look like my son. They look like my family, and it's just a very emotional thing.
Either of Rebecca or John want to add anything to that terrific response, I thought?
I would agree that it's important for us as people who are witnessing firsthand the impact of gun violence or whatever issue we're talking about. I think it's important for us to stand up and discuss our points of view. I will say that as a junior faculty member, it has been interesting for me to learn how to navigate that. When I get asked to speak in support of a ghost gun bill or a bill related to traffic violence. It is something that I consider, what are the bounds of what I can discuss in my role as a UC employee? What can I discuss as a private citizen? And I do think about those things.
Sure.
I will never, I'm not going to change anything that I won't say anything I don't believe in, but I do think that there are certain forums where, I can speak a little bit more freely, and some where I need to be a little bit more measured in order to get the point across.
Yeah. John, anything to add?
No, I mean, I think the only thing I'll add is we're lucky to be at this institution where we feel very supported. I remember at the very beginning when I entered doing a little bit of research in this domain, I actually met with Stan Glantz, who was like, let me give you the lay of the land of like what this is going to be like if you get a sort of no pun intended, a target on your back. And
Stan was a international leader in tobacco control and made a massive difference in that area. And so sort of experienced this firsthand in that arena.
Yeah. And so, I think I feel very fortunate to be, at an institution that I feel very supported in that realm.
Great. If you have questions, please send them in. We have one. It's one of the fun things about doing this online version. So this is a question from Carlos Del Rio, who is at Emory and one of the national leaders in public health. So Carlos, thanks for joining us. There are discussions now that we need to show more gruesome images of the consequences of gun injury, particularly with assault weapons. I've noted that you hear descriptions of them, but you actually don't see pictures in the media. What do you folks think about that? Does that go too far, or is that what you guys, particularly, actually all three of you see it, you know what it looks like, and if the public saw it, would that move the needle, do you think?
I could take that a little bit.
Go ahead, Andre.
Yeah, first of all, Carlos, how you doing? I've seen you all over TV. It's great thanks for your question. I appreciate that. And it's great that you're broadcasting nationally there, Bob. Congratulations. I think that there are lines that you can't cross when you're doing things. I got called by the governor, and the reason why I got called by the governor to speak at a press conference about assault weapons because he had heard me speak. So I'll do some detail verbally, but I think showing the pictures are, there's issues of patient confidentiality. There's all kinds of things that go, and you can actually look online and see all these things, that they are. I mean, the reality is that these weapons, they pulverize tissue, and there's a little bit of goriness and unseemliness, I think, as physicians, if we show the pictures of our patients. Now, professionally, like if I'm doing a talk on gun violence at a trauma conference, I'll show some pictures of damage that they do, but I don't do that in public, although I'll speak about it verbally and describe things in detail that I've seen and problems that these weapons cause. So I think that's sort of where we're at. I mean, the other thing is that, the folks think about this. I mean, a lot of folks from Sandy Hook, they were, when the Uvalde shooting happened and those 19 young children were murdered and their two hero teachers, that showing the pictures of what's left of the children is not something that it is. They talk about this Emmett Till moment, right? Emmett Till, those of you who don't know, he was lynched when he was visiting Mississippi, and it was just a terrible thing. And his mother opened the casket after he had been strangled and left in water for days, and it really sort of spurred on the civil rights movement. But I think that things now, there's such gruesome stuff. I personally would not think that it's a good idea, but that's just my opinion. I think we can explain what it looks like and how terrible it is, and I think that's probably as far as we should go. But that's just my personal opinion. I'm interested to hear what.
Yeah, no, I guess my instinct is to agree with you, that I'm then queuing in on what Jahan mentioned, Stan Glantz, and the pictures of tobacco smokers, black lungs and lung cancers and all that is, we're moving and probably change the way you think about it. It's a tough call. Any other thoughts on this?
I think there was, when the NRA called out physicians for their advocacy, I think what you saw was an explosion of clinicians, not necessarily showing pictures of their patients, but sort of showing literally the blood spilled on their shoes. And maybe that adds some legitimacy to us as clinicians and healthcare providers who are fighting every day to try and save patients' lives, that I think gave us some credibility. But I agree with Dr. Campbell. Like I don't know that showing the lifeless body of a patient is going to necessarily do anything but just kind of turn people off. But I think it's helpful for people to see that we do have an expertise here, that this is not purely a sociological phenomenon or a criminal justice issue, or it is a medical issue, because they end up in our emergency departments, in our ORs, in our rehab facilities. The trajectory of these patients' lives change dramatically if they survive their injury, and so much of that is medical.
Yeah, Rebecca, I want to ask you the idea of the wraparound project and focusing on the victims. I guess some of the victims are involved in using firearms as well, but I guess I naively would have thought that the outreach would need to be to the people who did the shooting, not the people who received the bullet. So what are the characteristics of these folks that you are working with, and why is that the right population? I also wanted to hear where the funding for this comes from as well.
Yeah, I think it's a great question. And I think that really gets back to the underlying reason that so many of our patients are shot in the first place or stabbed. It goes beyond the fact that they were in a place where somebody had a gun and fired it. And it goes much further back to some of the things I was discussing in my talk, the systemic inequities and structural racism within our society that has created communities and neighborhoods that are so just systemically minoritized and disadvantaged because of what we've done as a country, that opportunities don't exist in the same way that they do in other communities. And that kind of stressor, which Jahan mentioned when he was talking about COVID and how violence had increased during COVID, when those types of stressful community situations occur, that's when community violence erupts. And so there is, of course, benefit in interventions with perpetrators, people who have caused violence. But looking at the more kind of upstream factors, it's really important to talk to victims and figure out what was it in your life, what is it in your community that is not being addressed that we need to address in order to help you be safe and healthy and happy and help your family have more opportunities. And that's really how we combat violence in the community. Mm-hmm. As far as our funding, we are very, very fortunate to have the support of the mayor's office. The vast majority of our funding comes from the mayor as well as the Department of Child, Youth, and Families. And that is it's just a blessing for wraparound. HVIPs throughout the country really struggle and have had to patchwork together different ways of finding funding for these important roles. There is also finally a groundswell towards trying to start paying violence prevention professionals through Medicare. And there's actually a bill in the California State Senate that's making its way through right now to allow our VPPs to reimburse through Medicare, which would be a huge game changer to all of the programs in California.
Great, thank you. Jahan, what's the most important, if you could, if the federal government said, we're going to put a bunch of money to answer one important research question, what would it be?
That's not answerable. I don't know. I mean, that's a really tough one.
My specialty is asking non-answerable questions. So,
Bob, if you could have one superpower, what would it be? Yeah, I mean, I think. Well, I think from my standpoint, I would focus that energy towards where's the most benefit going to be. Right. We know that there are more firearm deaths that are suicides than anything else, right? And so we hear a lot that like it's a mental health issue, all this gun violence is a mental health issue, and it is, but not for the reasons that like a lot of talking heads bring up, right? So I think what I would probably focus my energy on is better to sort of refine our gun violence restraining orders or these red flag laws, and figuring out, how do you increase the sensitivity and specificity of those types of programs so that you can really intervene on folks who are most at risk. And that includes, not just folks that are, let's say, at risk of self-harm, but it includes our aging population, right? That have some cognitive decline, but have firearms and have had them for a very long time. I think clinicians are relatively good at having a conversation. Geriatricians, for example, are great at having a conversation about when do you stop driving? Well, when do you turn in your guns, right? We don't know the answer to that. And so really trying to understand, how do we get how do we expand this concept of lethal means restriction? We take folks that are either acutely or for, in the long haul at risk of injury, and we restrict their access to things that will actually kill them. And we know case fatality rate of firearms, at least used towards oneself, is 90-95%. If we can take that means away, that number plummets. The next closest means of suicide has a case fatality rate that's well under 50%, or in some instances it's less than 5%. So you start seeing a lot fewer deaths. And so that's where I think there needs to be more research, so that all clinicians out there understand this and know how to, intervene on behalf of their patients when they recognize that they're at risk.
Yeah, maybe the follow-up that came from Bimala Schwartz, who runs our Division of General Medicine at the county. How do you suggest we document risks of gun violence in the EHR? And I guess as we get better at pinpointing what are the risk factors and then what the intervention is when you identify those, that this becomes even more important. But do you have a way of thinking about the documentation piece?
Yeah, I think two things to say about that. One is, I think physicians don't ask or document because they don't really know what to do with the results, right? If my patient tells me they have access to firearms and I don't, what am I going to do with that information, right? So I'll tell you, for myself as a practicing emergency physician, every time I have someone who is brought in on a psychiatric hold, that is something I want to know because of that sort of high case fatality rate associated with having access to a firearm. So I document that. I make sure I send the residents back in the room all the time. Please go ask about firearms and let's document that. I think it's important to know. The other piece I'll say about this is that there was, this was in Florida years ago when with Governor Rick Scott, there was this whole docs versus Glocks debate about how there was a bill introduced that said that physicians cannot, as a matter of routine, ask about firearms and document that in the chart. Now you could, the exception was if it was immediately pertinent to that individual's case, you could, but they were really going after pediatricians who are screening for do you have a pool cover on your house, on your pool, and do you have a gun at home, and how do you store it? And the thought was, this is going to get an electronic health record, and then you're going to keep track of who's got guns. And there was a back and forth, and that ultimately did not become law, but other states threatened to do the same thing. And, I think the state of where things are going in America right now, I wouldn't be surprised if we start seeing some of those restrictions creeping back up. So we have to be careful, but I think if it's pertinent to your patient's care, I think it's important to document it, and then it's important to document, what you did with that, right? If I'm working at the county, I might say I refer that patient to wraparound because they have access to firearms, they have unmet social needs, they are at risk, and I think that wraparound could help them with services that might prevent that next injury.
Right. Let me just ask you something next. Yeah, I'll just sort of say, so the Committee on Trauma about 5 years ago, and actually the Board of Governors of American College of Surgeons, biggest umbrella over us, we convened a session on gun violence with about 100 different groups involved. And actually there was a document that came out of that, and it made recommendations about things. And it was like simple things like, locks, safe storage, gun locks, things like that, making sure people who have psychiatric illness don't get it. And some of the things that were just passed about, better background checks and all that. And it turns out that in the groups, at least from the college and the Committee on Trauma, which is the biggest group of trauma surgeons in in the country, there was about 80 to 90% agreement, and half the people in the Committee on Trauma actually were former military people who own weapons. So there's a lot of agreement even about that. But as the discussion sort of came out from the leadership of the college, the Committee on Trauma, into the greater body of the college, which is 80,000 members, there was a lot of pushback that was really quite severe. And as the word got out, it sort of became a little bit more. So we have lots of work to do in terms of educating folks, because there are folks, and I remember having a discussion that this kind of blew me away. Just after the 1 October shooting, that's the Las Vegas shooting that took 60 lives and 500 people were shot. I was sitting next to a friend of mine who's a trauma surgeon in Kentucky, and I said, "Can you believe that guy had 43 guns?" Right? And I said, then the guy looked at me. This is a trauma surgeon. He said, "I have 43 guns at home." And I said, "You have 43 guns?" He's like, "I have that." I said, "Well, I have 5 AR-15s." And I was just like, and I sat there and I talked to him for half an hour, and I realized that there was a real difference in the way that the world is viewed by people in California, New York, Massachusetts, and the way that things are viewed in the center of the country, in Kentucky, Texas. Even I went to do grand rounds at Baylor with my friends who are all trauma surgeons. Like 7 of them were armed with weapons, right, that they left in their car. And the only people not armed was me and like I'm the guy from Connecticut, right? This is a whole.
I want to be sure you give a good talk. Yeah.
Yeah. It was, I'm saying that the country is in a different place than we are in California, certainly in San Francisco. And we have to realize that, because at first I kind of wrote off a lot of folks. And then I started actually talking to some of the NRA types, and their view of the world is quite different than how we see things. Certainly as physicians and as healthcare professionals, and certainly as trauma surgeons, ED physicians, medical doctors, their view of the world is totally different. But even in our midst, there are folks who believe the issue of making sure you are armed to the teeth, and they have armories in their houses.
Mm-hmm. Well, we're at the hour. This is really incredibly important topic, and thank you all for your work and your programs and your advocacy, and sort of pushing us to be in this lane. The lane's incredibly important, and there are political constraints on what can happen, but we have to continue to push to make things as safe as we can. And I appreciate your work in this area. Thanks so much. Be well.